course of the day. Maybe 2 years ago, going from bringing her to the hospital.
Like jumping from one topic to another, is isn't it a manic phase? Okay. Okay. Manic episode box. 1 week, more than 1 week of irritable mood, more than 1 week of irritable mood and increased energy or activity. Three or more than three of the following symptoms. Four if mood is irritable. Only four if mood is irritable only. The mnemonic is dig fast, distractibility, impulsivity or indiscretion, risky behavior, grandiosity, flight of ideas, increase activity, flight of ideas, increase activity, decreased need for sleep, and or pressured speech. Talkativeness or pressured speech. Severity, impaired psychosocial severity impaired psychosocial function, may have psychotic features, hallucination, delusion, may require hospitalization. Okay, and this patient's week-long history of abrupt behavior change. Abrupt behavior change is characterized by the following: irritable mood, increase activity, impulsivity, pressured speech, flight of ideas. These changes are consistent with a manic episode of bipolar 1 disorder. In addition to marked symptoms, during a manic episode, patients may exhibit psychotic feature which must be differentiated from the psychotic disorder. Delusions in mania often involve grandiose themes in which patients believe that they have special abilities or powers, uh, or are extraordinarily talented, running from public office, that others are jealous of them. In contrast to primary psychotic disorder, delusions in bipolar disorder are present only during the active mood episodes. The mood episode are The mood episode at the onset of the bipolar disorder may be manic, as in this patient, hypomanic, depressed, or mixed. At least one manic episode is required to diagnose bipolar 1 disorder. A history of a depressive episode is not required for the diagnosis, although most patients experience both manic and depressive episodes over the course of lifetime. Got it? It may be Dhat syndrome, DHAT. This is you don't know because this syndrome is common for India. This like India is just beside our country. Like India, Bangladesh, these are the nearby countries. So in this country, there is kind of this syndrome is present. Dhat syndrome, THA. Okay, we will see on discussion. Okay. Okay, it's abnormal. It's not abnormal, it's a normal. Like there is nothing, no problem in this type of patient. Okay, these patients. Okay, these patients somatic symptoms: fatigue, weight loss, anxiety, cultural background, Southeast Asia, and belief that he is losing semen during urination are consistent with Dhat syndrome. Dhat syndrome is a culture-bound syndrome found in South Asian cultures, in which sufferers attribute a range of psychological and somatic complaints to the loss of semen via various methods: loss of urine, excess masturbation. Culture-bound syndromes and culture-bound syndromes are illness or explanation of illness that are unique to specific cultures. Due to a challenge of becoming familiar with all the various culture manifestations of illness, physicians must approach the treatment of unfamiliar culture-bound syndromes from a patient-centered approach. Patient-centered cross-functional culture empowers parents to educate the physician on the belief about their illness. Physicians facilitate this education by adopting an open and inquisitive communication style that explores the cultural explanations, manifestations, and consequence of the illness. This patient has provided a description this patient has provided a description of his illness but has not been given an opportunity to share his belief about its causes. Therefore, the most appropriate next step would be ask an open-ended question to explore these beliefs. Okay, you got the idea? Okay, it is just an information like there is this such kind of syndrome present. I think so because he has the tendency of doing suicide. Okay, patients sometimes deny that they have made a suicide attempt due to either stigmatization or desire to reattempt. The physician has a duty to assess the likelihood that an attempt has been made and the risk for further self-harm. Despite his denial, this patient has likely attempted suicide and at is at high risk for repeated attempt. He has numerous risk factors for suicide, including features suggestive of depression, weight loss, poor sleep, um, anxious effect, unemployment, living alone, risk of homelessness, and worried about paying rent, and active substance use, as well as a likely recent attempt. Physicians should use their clinical judgment when assessing suicide risk and must always act to ensure patient safety. This patient should be hospitalized for his own protection on involuntary status if unnecessary. It would be inappropriate and unsafe to manage his condition in an outpatient setting. Next, okay, so this patient's behavioral change, socially offensive behavior, social withdrawal, compulsive behavior, consuming the same meal daily, hyperorality, recent increased cigarette consumption, apathy, lack of insight, and executive function, difficulty with tasks that require planning, are consistent with the diagnosis of behavior variant frontotemporal dementia. Disinhibition is often a prominent component of the behavioral change seen in frontotemporal dementia. Unlike in Alzheimer's disease, memory impairment is generally mild in early frontotemporal dementia but worsens as the disease progresses. Frontotemporal dementia typically presents around the age 60, affects men and women as equal rates, and follow an autosomal dominant pattern of inheritance. In up to 25% of cases, the degenerative process of the frontotemporal dementia progress more rapidly than other dementing syndrome, Alzheimer's disease, and the average length of the survival following diagnosis is 5 to 10 years. Behavioral variant frontotemporal dementia is most often associated with accumulation of tau protein inclusion known as pig bodies in the hippocampi, temporal lobes, and frontal lobe. SSRI, sertraline, escitalopram, and trazodone have demonstrated some benefit in the management of neuropsychiatric symptoms of frontotemporal dementia. Next. Okay, it's
Next,
why it is not vascular. Okay, I'm reading the box. Okay. Alzheimer disease. In Alzheimer, there is early insidious short-term memory loss, early insidious short-term memory loss, language deficits, and spatial disorientation, later personality change. So early memory loss, later personality change. In vascular dementia, there is stepwise decline, early executive function, stepwise decline, early executive function, and cerebral infarction, and or deep matter changes on neuroimaging. In frontotemporal dementia, there is early personality changes, apathy. Frontotemporal dementia, early personality changes, apathy, disinhibition, and compulsive behavior. Apathy, disinhibition, and compulsive behavior, and frontotemporal atrophy on imaging. And in dementia of Lewy bodies, there is visual hallucinations, spontaneous Parkinsonism, visual hallucination, spontaneous Parkinsonism, fluctuating cognition, and rapid eye movement behavior disorder. In NPH, there is dilated ventricle on imaging, urinary incontinence, and ataxia early in this disease. And Prions disease, behavioral change, rapid progression, myoclonus, and a rod seizure.
the development of vascular is different about the diabetes and the diabetes. It has to see with patient development and with the physical disorders, which is early dementia.
Okay, it's a somatic symptom disorder. Okay, first box. In somatic symptom disorder, one or more than one unexplained symptoms, excessive thoughts, anxiety behavior in response to symptoms. In illness anxiety disorder, minimal to no symptoms, preoccupation with idea of having a serious illness, preoccupation with idea having a serious illness, functional neurological symptom disorder like conversion disorder, neurologic symptoms incompatible with anatomy and pathophysiology, neurologic symptoms incompatible with anatomy and pathophysiology, factitious disorder, falsification of symptoms, including injury in the absence of obvious external rewards. And malingering is falsification or illness for obvious external reward. So factitious is a falsification of symptoms in the absence of external reward. Or malingering, they want reward. Falsification of illness for obvious external reward. Okay. These patients' persistent excessive anxiety and time-consuming behavior in response to her abdominal pain are most consistent with somatic symptom disorder. Patient with somatic symptom disorder typically patient with somatic symptom disorder typically consult multiple providers and undergo extensive diagnostic testing with negative results. Although although these patients frequently have multiple somatic symptoms, only one pain in his patient is required for the diagnosis. The symptoms may be associated with another medical condition and concurrent medical illness that is mutually exclusive. Somatic symptom disorder can be differentiated from anxiety disorder from previously known as hypochondriasis by the presence of significant somatic symptom. Patients with illness anxiety disorder have minimal to no symptom. They are concerned primarily with the idea they have serious illness. Okay, next. I thought it's Wernicke, but it's Korsakoff. Okay, these patients retrograde and anterograde amnesia with intact long-term memory, confabulation, apathy, lack of insight, and history of alcohol use disorder are most consistent with diagnosis of Korsakoff syndrome. So these patients retrograde and anterograde amnesia with intact long-term memory we are more consistent with the Korsakoff syndrome. Korsakoff syndrome is a potentially complication of Wernicke encephalopathy, an acute use disorder of thiamine deficiency characterized by the classic triad of encephalopathy, ataxia, oculomotor dysfunction. Although Wernicke encephalopathy may be seen in conditions other than alcohol use disorder, anorexia, hyperemesis gravidarum, the risk of Wernicke encephalopathy progressing to KS, Korsakoff psychosis, Korsakoff syndrome, is much higher in alcohol use disorder than in other Wernicke associated conditions. However, in some patients who abuse alcohol, KS may develop without a recognized acute Wernicke encephalopathy as seen in this patient. Although patients may experience significant recovery of of function in Wernicke encephalopathy in thiamine supplementation, recovery is rare in Korsakoff psychosis, Korsakoff syndrome. Korsakoff syndrome is associated with lesion in the anterior and the medial thalami as well as corpus callosum. The neuropathologic findings in Wernicke syndrome include mammillary body atrophy, dorsomedial thalamic neurons. Medial thalamic neurons. Okay, it's not option B. In dissociative amnesia develops in the context of psychological trauma and affects traumatic autobiographical memory and is frequently reversible. There is no evidence of trauma. There is no evidence of trauma in this patient whose memory deficit who- whose memory deficit involved widespread memory symptoms. And Marcia Faba Bigmani disease presents with dementia, motor dysfunction, and dysarthria, like problem in speech articulation. Uh, it is associated with severe damage in the corpus callosum and surrounding white matter in the context of chronic alcohol use disorder and attendant malnutrition. Okay. He's just sad. There are two things we can do, either ECT or metazapine. Metazapine helps in weight gain, isn't it? Yes, that's the thing. He has decreased appetite. He has no difficulty falling. Everything is all right. Okay. Think about this is the question of the GIT I have done, like pancreatic cancer can come with low mood, major depression. This is the thing. Yes, that's why I thought that is it metrazapine, because but like for antidepressant property. Okay, then we miss the shot. Okay, this patient has features of major depression, low mood, isolation, weight loss, low mood, isolation, weight loss, and anxiety. However, given in this age, marked weight loss, recent diagnosis of the abdomen, recent diagnosis of diabetes mellitus, despite lack of obesity. This presentation is concerning for pancreatic cancer. Depression and associated anxiety are prodromal feature in more than one third of the patient with pancreatic cancer. Patient may describe as non-specific study a premonitory sensation something bad is going to happen, premonitory sensation something bad is going to happen, feeling low for no reason, and the feeling low for no reason. The mechanism is not clear, but the hypothesis include increase the inflammatory cytokines IL-6, a paraneoplastic syndrome, and alteration in pancreatic function, hormone secretion, as seen in this patient. A new onset atypical diabetes and diabetes mellitus, new onset atypical diabetes mellitus in a thin older individual may also precede a diagnosis, may also precede in up to 25% of the pancreatic cancer. In this patient, the pathophysiology of the diabetes mellitus is possibility due to cancer-induced beta cell dysfunction and or secretion of adrenomedulin, the insulin regulating peptide hormone. Okay, therefore the next step, the workup is to do CT scan of the abdomen, which is preferred initial imaging test in non-jaundice patients presenting with severe weight loss and other suspicious symptoms. Okay. So these patients new onset, time consuming, intrusive uh, uh, obsessional fear and are associated compulsive behavior, excessive washing and showering are consistent with OCD. Pregnancy and the postpartum period Pregnancy and the postpartum period are associated with increased risk of this new increased risk of new onset recurrence exacerbation of OCD. As in this case, the obsessional thoughts and compulsion often relate to the health and safety of the baby, fears of contaminating and harming the baby, excessive washing. New mothers with OCD may be reluctant to disclose their symptoms and come to clinical attention only when a partner or family member become concerned. Mild cases of postpartum OCD are treated with CBD. Management of moderate to severe include SSRI, serotonergic antidepressant, after consideration of the risks of pharmacotherapy versus the risks of untreated OCD. Okay, okay. Okay. These patients' progressive memory loss and executive dysfunction are most likely due to Alzheimer's disease. He has a typical presentation of the disease, age of onset more than 65, early and relatively isolated memory loss, gradually progress, functional decline. The MRI findings are non-specific and generalized atrophy are characteristics of Alzheimer's disease. Alzheimer's disease, the most common cause of dementia in the US, typically occur after the age 65. Although this patient has a history of HIV, his illness is although this patient has a history of HIV, his illness is well controlled on antiretroviral therapy. He has an undetectable. Can I call you after a minute? My sister is calling. Okay. Yes. Now. Okay. This is Alzheimer's disease. I'm reading the explanation. Okay. Second para. Okay. Although this patient, although this patient has a history of HIV infection, his illness is well controlled on antiretroviral therapy, and he has an undetectable viral load. He has an undetectable viral load. HIV-associated dementia had occur. HIV-associated dementia occurs almost exclusively in untreated HIV infection. HIV infected patients with advanced disease. CD4 count is less than 200 with AIDS. In contrast to the characteristic cortical dysfunction seen in AD, amnestic syndrome, the HIV-associated dementia is subcortical dementia characterized by apathy, early impairment in attention, subcortical motor symptoms. Because HIV-infected patients are living longer. Common forms of dementia such as AD are much more likely etiology because of dementia in antiretroviral treated patients. Okay. He sat for only 2 months. So for, hmm, okay. I don't know how they made this major depressive disorder. Okay, this patient's 2 month history of depressed mood, feeling down like me. Okay, social isolation, social isolation, loss of interest, fatigue, low energy, hypersomnia, laden paralysis. My legs are in cement blocks. Weight gain is most consistent with atypical subtype of MDD. A core A core feature of atypical depression is mood reactivity, positive responsiveness to pleasant event. Other characteristics features include increased appetite, weight gain, hypersomnia, latent paralysis, heavy feeling in limbs, and hypersensitivity to rejection. These patients' ability to enjoy the family reunion and smile during the interview are examples of mood reactivity and characteristics of atypical subtype. In contrast, the melancholic subtype of MDD is characterized by weight loss, insomnia, and pervasive anhedonia with an inability to respond positive events.
Can you read this one, please?
Yes. Okay, MDD can be differentiated from adjustment disorder and normal stress response. So normal stress response by the number of severity of the symptoms and the degree of functional impairment. Adjustment disorder involves depressive symptoms developing within 3 months of the stressor with resultant functional impairment, but insufficient number and severity of symptoms to meet the criteria of MDD. A normal stress response is not excessive or out of proportion to the severity of the stressor and does not cause functional impairment.
Next, even if I know emergency environment, isolation,
Low, yes, very low. Bicarbonate is low. Yes, normal. 70 to 120 maybe. Okay, 110. Flushed. It's flushed. There is nothing about pupil. Another clue is severe hyponatremia. Okay, these patients presentation suggests MDMA intoxication complicated by serotonin syndrome. MDMA formulated as ecstasy, MDMA formulated as ecstasy or Molly, and has mild hallucinogenic properties and is sometimes used by the college students during parties to cause euphoria and increase sociability, alertness, empathy, sexual desire. MDMA is a synthetic amphetamine that exerts its effects by increasing synaptic levels of norepinephrine, dopamine, and serotonin. Severe intoxication may manifest with the features of sympathomimetic toxicity, serotonin toxicity, sympathomimetic toxicity, hypertension, tachycardia, diaphoresis, hyperthermia, and serotonin toxicity, serotonin syndrome, altered mental status, hyperreflexia, myoclonus seizures, and hyponatremia due to drug-induced inappropriate ADH hormone secretion as well as excessive water intake to reduce hyperthermia. Combining MDMA with other serotonergic drug sertraline, as in this case, further increases the risk of serotonin syndrome. Further increases the risk of serotonin syndrome. Serotonin syndrome further increases the risk of serotonin syndrome. Mm, as well as okay. Okay, combining MDMA with other serotonergic drug, sertraline, as in this patient, further increases the risk of serotonin syndrome. Coma and death may result from acute intoxication, and long-term use has been linked to neurotoxicity. Recreational sympathetic amphetamine and analogs, MDMA bath salts, may not show up as amphetamines in routine urine toxicology screen. Okay, yes. Okay, intoxication syndrome in drugs of abuse. NMDA antagonist, PCP, ketamine. NMDA antagonist, PCP, it causes violent behavior, dissociation, hallucination, amnesia, nystagmus, and ataxia. Nystagmus and ataxia, violent behavior, dissociation, hallucination, amnesia, nystagmus, and ataxia. MDMA, euphoria, tachycardia, hypertension, hyperthermia, serotonin syndrome, hyponatremia, seizure, and mydriasis. Benzodiazepine, CNS depression, normal vital signs, slur speech, ataxia, and coma. Slur speech, ataxia, coma. Opiate narcotics. Opiate narcotics, euphoria, depressed mental status, euphoria, depressed mental status, respiratory depression, meiosis, and constipation. Opiate narcotics is euphoria, depressed mental status, respiratory depression, meiosis, and constipation. So these patients' presentation suggests of MDMA. Okay, I've read the description. Okay, so what is the take home? Like in NMDA, uh, okay, N for nystagmus, M for amnesia, and D for dissociation, and A for ataxia. So NMDA, these four. NMDA antagonists are PCP and ketamine. So nystagmus, M for memory impairment like amnesia, D for dissociation, and A for ataxia. So NMDA goes for NMDA. Okay, and MMDA, what MMDA cause mydriasis. Mm, okay, no, there is no mnemonic here. And benzodiazepine, we know that. Yes, yes. One Okay. So benzos with opioid and NMDA with MMDA. No, oh, not really, but okay. So for MMDA, we will remember like it can cause serotonin syndrome if it is associated other, and it can cause SIADH like hyponatremia, and it can cause hyperthermia, seizure, this kind of feature. And NMDA with nystagmus and violent behavior, and benzos with the CNS depression and normal vital sign. But opioid with respiratory depression and meiosis. Okay, meiosis constipation. Okay, these patients show acutely agitated behavior that poses a safety risk to the emergency department staff. Diagnose, Diagnostic possibilities include a manic episode with psychotic feature, grandiose delusion, hyperactivity, pressure speech, substance use psychosis, psychosis due to another medical conditions, uh, and and psychotic disorders. If verbal dissociation If verbal dissociation is unsuccessful, administering a benzodiazepine lorazepam would be most appropriate. Lorazepam would be most appropriate pharmacotherapy to manage the patient's escalating agitation. Can be administered intramuscularly for a more rapid effect. Administration of a first or second generation antipsychotic. Administration of a first or second generation antipsychotic haloperidol, olanzapine, risperidone, ziprasidone is another opinion for management of acute agitation. The first generation antipsychotic haloperidol is often co-administered. Haloperidol is often co-administered with lorazepam to achieve more rapid sedation in severely agitated and combative patients. When the patient is calmer and cooperative, further workup, urine, drug, skin chemistries, and complete blood count, thyroid function tests would be indicated to rule out the substance related medical cause of psychosis. Got it? Okay, it's reaction formation. Reaction formation is a defense mechanism in which an individual transforms an unacceptable emotions, desire, and impulses into extreme opposite. This woman resents having to care of her father to avoid feelings of guilt. However, her resentment is unconsciously transformed into exaggerated, over solicitous behavior, being extremely attentive, repeatedly offering to get him water. Although individuals are not aware that they are exhibiting these defense mechanisms, it is often readily apparent to others. Okay, other option like altruism occurs when a person manages an unpleasant emotions through unsolicited, generous service to the others, organizing a support group for caregivers. These service providers, this service provides the person with gratification. In contrast, this patient resents having to care for father, considering it an obligation rather than deriving gratification from it. Rationalization. Rationalization occurs when someone rationalization occurs when someone makes excuses or justifies one's own behavior to avoid the truth. If the woman chose not to bring her father to the physician due to resentment, but unjustified her decision by saying that the checkups are unnecessary unless something is obviously wrong. And the option D in splitting, unable to integrate mixed feelings, thereby seeing others as bad or as good. This woman does not have mixed feeling. She is responding to her negative feelings toward her father with an overly attentive behavior. Got it? Okay, sorry, sublimation. Okay, next.
The fear of the brought to the person by the expressing that they believe it is wrong.
Okay, so it's nightmare disorder. This girl, this girl's recurrent awakening with associated dream content, and or ability to be consoled, and most consistent with nightmare disorder. Diagnosis require recurrent episodes of awakening from sleep with recall of highly disturbing and frightening dream content. On awakening, the child is fully alert, remembers the dream usually be consoled can usually be consoled. Although frightening, nightmares are typically transient and developmentally normal for most children. Nightmares occur during rapid eye movement, sleep, REM sleep. Nightmares occur during rapid eye movement, sleep, and are more frequent in the second half of the night. Okay, sleep terror disorder is consistent with non-REM sleep arousal disorder characterized by incomplete awakening, unresponsiveness to comfort, and no recall of dream content. Sleep terror, in contrast, non-REM arousal disorder associated characterized by incomplete awakening and unresponsive to comfort and no recall of the dream content. Sleep terror typically occurs in the first third of the night, characterized by marked autonomic arousal and amnesia for the episode in the morning. Okay, so nightmare is like patient is fully aware and he can fully it is REM sleep behavior disorder and it happens in the second half of the night. So it's REM sleep behavior disorder occurs in the second half of the night and patient is fully alert and remembers the dream. But sleep terror patient he cannot remember the dream, non-REM sleep and incomplete awakening. Okay,
Read this one.
okay. Choice E. REM sleep behavior disorder. REM sleep behavior disorder involve repeated episodes of complex motor behaviors, repetitive episodes of complex motor behavior and vocalization during REM sleep.
Yeah, so for example, this REM sleep behavior, schizophrenia episodes.
So how these two can be differentiated? Like all the features are the nightmare.
Yes,
Okay, eating less, weight loss. Yes. Okay, box first. MDD more than 2 weeks, 5 out of 9 symptoms. Low mood, anhedonia, sleep disturbance, appetite loss, energy loss, psychomotor retardation, psychomotor changes, gut, guilt or worthlessness, concentration difficulty, suicidal ideation. May occur in response to a variety of the stressor including loss of the loved one. Suicidality increases suicidality related to hopelessness and worthlessness. Grief reaction. Grief reaction, normal reaction to loss. Sadness, more specific to thoughts of the deceased. Waves of grief at reminder. Self-esteem easily preserved. Functional decline less severe. Thoughts of dying, even if even thoughts of dying involve wish to join the deceased activity. Suicidality uncommon and intensity decreases over time. So grief, okay. So although these patients major depressive symptoms develop in response to stress or of bereavement, his symptoms are sufficient in number and duration and severity and meet the diagnostic criteria of MDD. For 2 weeks, patients with major depressive disorder and no history of mania or hypomania are diagnosed with major depressive disorder. DSM allows the diagnosis of the MDD during bereavement. During bereavement, mm, during bereavement period, because evidence has shown that bereavement-related major depression and bereavement-related major depression not related to bereavement have similar course and response to the treatment. The death of the loved one is often similar to any other serious stressor that can trigger a major depressive episodes. Major depression can be difficult to differentiate from the acute grief. In normal grief reaction, sadness, okay. In normal grief reaction, sadness is typically focused on the deceased and decreases in intensity over several weeks with intermittent waves of grief mixed with positive memories. Okay, next. Okay, it's a dissociative amnesia. So patients' inability to recall important autobiographical information is suggestive of dissociative amnesia. It can consist of a localized or selective amnesia for a particular event, or as in this patient, more generalized amnesia for personal identity and history. Onset is typically sudden and preceded by overwhelming of intolerable overwhelming or intolerable events. If the amnesia is associated with traveling or walking, the term dissociative fugue, previously a separate diagnosis in DSM-4, used as oh, if the amnesia is associated with traveling or wandering, the term dissociative fugue, previously a separate diagnosis in DSM-4, is used as a specifier for dissociative amnesia in DSM-5. Okay. Definitive diagnosis required to rule out the effects of substance, alcohol, blackout, or a neurological condition. Dissociative amnesia is not diagnosed if the disturbance is better explained as a symptom of acute or post-traumatic stress disorder or dissociative identity disorder. Can you differentiate these three, like depersonalization, dissociative amnesia, and DIDs? Okay, say it. Okay, next. maybe actual disease. And important, there is a fever also. Okay, this patient's psychiatric symptoms: anxiety, psychosis, insomnia, aut- uh, autonomic instability like hyperthermia, hypertension, tachycardia, cognitive impairment, rigidity, hyperreflexia, dystonia, focal seizures after a flu-like prodrome. After flu-like prodrome in the setting of non-ovarian teratoma strongly suggests anti-NMDA receptor encephalitis. This is a form of encephalitis, tends to present a multi-stage syndrome with characteristics feature anti-NMDA receptor. Anti-NMDA encephalitis has a median age of onset has a medium age of onset 20 medium age on the onset age 21. It is 4 times more common in women who more than 50% have increased more than 50% have an increased ovarian teratoma as seen in this patient. This clinical diagnosis can be confirmed by the presence of CSF fluid to the gluon subunit of NMDA receptors. Because of the association with the tumors, patients with NMDA receptor encephalitis, NMDA receptor encephalitis should undergo imaging. If applicable, prompt tumor removal often prompt tumor removal has been associated with better outcomes. Regardless of the presence of a tumor, immunosuppressive treatment is the cornerstone of the therapy. Recovery is often slow, but 4 of 5 patients recover within minimal sequelae of 2 years. Oh, yes, you can say it. An NMDA receptor encephalitis, one of the paraneoplastic syndrome. I have gone through my old theory. Like, if the patient is acute and agitated, what is your choice? And look at the question. Like, this patient uh, actually close if you look at the drugs, like close up in causes agranulocytosis like neutropenia. It does not cause like recent this agitated behavior or aggressive behavior, isn't it? And he he was outside home, like he is not in his normal state. And most of the people in the western, they actually take alcohol every day, most from now uh, on and off. Like, look at this line, he does not use tobacco or recreational drug, but he does use alcohol. So there is a gap of having alcohol in this period, like when he is on his mother's house. Got it what I'm trying to say? Okay. Okay, now I am reading the explanation. Although it can be, although it can go unrecognized, substance use disorder often occurs in patients with schizophrenia. Up to 50% patients with recently diagnosed schizophrenia already have a diagnosis of alcohol or drug use disorder. This patient with a history of schizophrenia and alcohol use develops signs of alcohol withdrawal, likely precipitated by suddenly losing access to alcohol when to a group of home moved to a group home. Clue to the diagnosis include the time of course symptoms, calm and cooperative the first day, restless and agitated the second day, and manifestation of sympathetic hyperactivity, elevated blood pressure, tachycardia, diaphoresis, and tremor. Withdrawal symptom typically starts within 6 to 24 Withdrawal symptom typically starts within 6 to 24 hours after the last drink. Alcohol withdrawal seizure can occur within 12 to 48 hours, and delirium tremens, disorientation, disorganization, fever typically begins with 48 to 96 hours. Benzodiazepines are the treatment of choice, and psychomotor agitation associated with alcohol withdrawal to prevent progression to seizure and delirium. Supportive psychological therapies may present such as anxiety, but they do not slow the progression of alcohol withdrawal. Okay, got it. Next. Okay, so this patient's presentation is consistent with major depressive disorder. Given his anhedonia, stopped spending time with his friends, discontinuing discontinued hobbies, sleep difficulties, low energy, fatigue, impaired concentration, missed deadlines, mistakes at work, weight gain, psychomotor agitation, increasingly anxious, restless that have lasted more than 2 weeks. Initial treatment of MDD include antidepressant psychotherapy or a combination of both. Antidepressant therapy is generally comparable across within classes and is comparable to psychotherapy alone. Most patients are treated with SSRI for the first episodes, but other classes SNRI can be selected based on additional feature factors. Adverse effect comorbidities. CBT cognitive behavioral therapy for depression, which focuses on identifying maladaptive belief and using behavioral techniques such as exercise to alleviate their effect. And interpersonal psychotherapy, which focuses on interpersonal conflict, grief, role changes, are efficacious and have benefits benefits that extend beyond the acute treatment of the period. Combined therapy consisting of antidepressant plus psychotherapy is more effective than either dose alone. Okay, next.
27-year-old comes to the office with anxiety and depression. Her temperature temperature is what is happening is something on that side is not very healthy, and something is happening on the brain is not healthy. So he asks her to
Not really. And there is other social affair. He has anxiety too. Yes. Not generalized. Generalized is excessive worries about multiple issues. So he is not worried about multiple issues. It is social. He is sad. Okay. Marked anxiety about one or more than one social situation for 6 months. For more than 6 months. Fear of scrutiny by others. Humiliation, fear of scrutiny of others, humiliation, embarrassment. social stimulants avoided or endured with intense distress, marked impairment, social, academic, occupational, and subtype specifier performance only. Treatment is SSRI, SNRI, CBT, and beta blocker or benzos for performance only subtype. So these patients' extreme anxiety in social situations and fear of scrutiny and negative evaluation are consistent with social anxiety disorder. These patients' fear of saying something embarrassing and his anticipatory anxiety about interacting with co-workers and feeling new people and meeting new people, like both work related and social, are characteristics of this disorder. His refusal of a job, his refusal of a job promotion that requires more social interaction in an example of the resulting functional impairment. Self-medication of the social anxiety with alcohol is common complication of this disorder. SSRI and SNRI are the first line medication for social anxiety inhibitor. Cognitive behavioral therapy is considered as a first line non-pharmacological treatment. Okay. Yes. Benzos such as lorazepam have a role in the treatment of performance only subtype of social anxiety disorder. They are less preferred in patients who have anxiety and in more generalized non-performance social situations such as meeting with new people and regular interaction with the co-worker and clients. In addition, benzodiazepines are generally avoided in patients with history of self-medication with alcohol, as in this case. Okay, next. Okay, he has bilateral swollen cheeks. Is I think that he has bulimia nervosa. Yes, that's why these dental caries, because as he is throwing, as she is vomiting, so the acid is causing the dental caries, and there is bilateral swollen cheeks due to vomiting. So he is throwing acid. Uh, Yes, and and there may be acidosis. No, pH may be increased in that case. Like vomiting causes metabolic alkalosis. Okay, so the physical examination findings: dry skin, dental caries, bilateral swollen cheeks, parotid gland enlargement, of a history of Mallory Weiss tear. Mallory Weiss tear are consistent with surreptitious self-induced vomiting, suggesting the diagnosis of the bulimia nervosa. Because patients with eating disorder often attempt to hide their condition, physical examination and lab assessment are often key to make the diagnosis. Excessive vomiting, which is commonly seen in bulimia nervosa, causes multiple metabolic derangements, loss of hydrochloric acid and potassium. Loss of hydrochloric acid and potassium in the vomit results in hypochloremic metabolic alkalosis. Level Metabolic alkalosis, increased pH, low chloride, dehydration, and volume contraction result in activation of renin-angiotensin aldosterone system, which causes secondary hyperaldosteronism and further worsens these abnormalities by increasing renal hydrogen and potassium secretion in exchange for potassium and subsequent water retention, as seen in this patient. So secondary hyperaldosteronism due to RAS, which causes increasing renal hydrogen and potassium excretion in exchange of sodium and water retention. As seen in this patient, peripheral edema may occur due to third spacing of the retained fluid. In addition to the characteristic finding associated with excessive vomiting, dental caries, parotid gland enlargement, patient may have symptoms related to volume contraction, dizziness, orthosis, and electrolyte abnormality, arrhythmia, weakness, and muscle cramps and constipation. Got it? Okay, so bipolar disorder is a highly recurrent illness, and multiple mood episodes are typical. The goal of maintenance treatment is to decrease the risk for recurrent manic and depressive symptoms that can severely impair functioning and relationships. Lithium is a first-line agent that has been studied extensively and helps decrease the rate of relapse in patients with bipolar disorder. Discontinuing stable lithium treatment usually leads to recurrent episodes within months to years and carries risk of hospitalization, economic losses, and suicide. Understanding the patient reasons for not wanting to be on medication and suspending to any specific concern he has about lithium are important. However, treatment recommendation must take into account high risk recurrent episodes. These patients are doing well on therapeutic dose of the lithium, no recurrent manic or depressive episodes since the starting of lithium for 2 years and tolerating the medication without difficulty. His medication history indicates that other treatment options, quetiapine, olanzapine, with fluoxetine results in unacceptable weight gain. The most appropriate response is to recommend continuing lithium at the same dose while monitoring for side effects. An analogy can be made to another chronic illness, asthma, that may require prolonged medication usage. Okay. Yes. Yes. He is in the. She is in the. Like with. She is not in the families. She is in with her roommate. Uh, so we need to see that she is taking something or not, even if the patient do not know. Like, okay, so this patient demonstrate signs of new onset psychosis, delusion, possible hallucination of unclear etiology, major depressive or manic episode with psychotic feature should be considered given the patient's history of depression and family history. Okay, the basic medical workup For new onset psychosis, commonly include complete physical and mental examination, metabolic panel, complete blood count, urine toxicology screen. It may also include for syphilis, HIV, vitamin B12 level, thyroid function, anti-nuclear antibody, as well as neuroimaging, depending on specific finding or risk factor. In a young patient with no significant family history, in a young patient with no significant medical history and normal physical examination results, obtaining a urine toxicology screen is the most appropriate next step in evaluation. That is, screen a positive for cocaine or amphetamine suggests stimulant induced psychosis. The parent should report cannot be relied on rule out the illicit or prescription drugs. Okay, next. Is it major depression with psychotic? Okay. Is it adjustment?
So the key is working first before resting, include working cardio, include rest, and include normal activity. So include physical therapy, include psychotherapy, include counseling, include mental evaluation.
Okay. So, narcolepsy. So, this patient's excessive daytime sleepiness, lapse into the sleep, unintentionally falling asleep in class, hallucination with falling asleep, cataplexy, transient loss of muscle tone in patients with intense emotion are suggestive of narcolepsy. Intrusions of REM sleep phenomena during sleep-wake transition may include hypnagogic and hypnopompic hallucination as well as sleep paralysis, inability to move immediately after awakening. Narcolepsy is associated with low cerebrospinal fluid of orexin A and hypocretin. Onset typically occurs during adolescence of the early 20s. Diagnostic evaluation includes polysomnography to rule out sleep disorder other sleep disorder and a multiple sleep latency test demonstrate decreased sleep latency or sleep onset REM periods. Okay.
Next, several important environment develop MDD by involving exposure to bright and vivid objects and scenes. Patient often experience vivid and border frequency. Hmm.
He is in depression, isn't it? Major depression.
Depression, why?
Yes, there is plenty of feature of depression, but I do not find the psychotic feature like fatigue, poor appetite, and she
Okay,
used to enjoy going out with friends. Now,
that's four. And then the psychotic is like she said that she's having compulsive behaviors, right?
oh
Can you
yes,
explain that?
yes, no, not persistent complex bereavement because this sounds more like this, but actually he has MDD along with psychosis. Okay. Okay, this patient's 1 month history of anhedonia, weight loss, fatigue, excessive guilt, and recurrent thoughts of death, in addition to mental status examination. Mental status examination findings of psychomotor retardation and delusion is most consistent with the diagnosis of major depressive disorder with psychotic feature. MDD with the psychotic feature is a severe subtype of MDD in which patient develops psychotic symptoms during depressive episodes. Delusion and hallucination are most commonly mood congruent and have depressive themes deserving punishment, worthlessness, bodies rotting. Although mood incongruent, psychotic symptoms unrelated to depressive themes can also occur. Identifying the presence of psychotic feature in MDD, and it is most MDD is important because treatment differs from non-psychiatric depression. Patients with MDD with psychotic feature require comorbid antidepressant and antipsychotic or ECT. Okay, okay, yes, yes, I have created the blog.